Hi everyone and welcome back to the channel, and today's video is a really important one and a fascinating one at that. We are going to be talking about the differences that you have got to be aware of when assessing young athletes compared to adults, and believe you me, there are some big differences that are going to shock you in this video, and if you didn't know them, you will never forget them after watching this video. So to do this, I'm bringing on to the channel Angie Jackson, who has 35 years experience working with youth athletes. She herself has been a high-level athlete in tennis and hockey. She's worked with the Canadian national teams in a variety of sports, and now she runs fantastic courses aiming at increasing the awareness for physios out there when treating youth athletes. So get that pen and paper handy, because this is a big one and this is really going to blow your mind and really shock you. So without further ado, let's roll the video. So we're going to first of all welcome Angela, and then we're going to dive into that title very shortly. So welcome to the channel, Angela.
Thank you very much. Thanks for asking me to join you.
It's brilliant. I'm really keen to. I've been keen to get you on for a little while now, seeing lots of really great content that you put out on social media that is all about aiming to increase people's awareness of youth athletes and kids. And it's something that I know as students and as new grads, we get very little coverage of this, certainly at an undergraduate level. So I think this is going to be really useful, and we're going to aim to help people get some real top tips of what they need to know, which will be really useful. Let's begin with that title as well, so that this one of active kids are not mini adults, because I think this is really important. Can you give us a bit of meat around the bones on that one, Angela?
Yes, of course. It was something that I'm really passionate about, is that at undergraduate level, we are not really taught about the differences between adults and children. And so what we tend to see is that a lot of people adopt either adult pathologies or adult approaches, sometimes adult exercise regimes, and just basically either land them straight onto that young child, or alternatively slightly adapt them in certain ways. And so what I really wanted to do was emphasize that these sort of little active sports people and that what we're really talking about there is the kiddies from usually around 8, 9, when they start playing 2 or 3 different sports. They're running around doing lots of different activities, and they start to get maybe some aches and pains. And yet what we're not clear about when we first graduate is what those diagnoses might be and how they might be different from some of the adult ones that we've come across at undergraduate level. So that's kind of the backbones of how I started. And so I think we just need to look at all the different systems that we need to look at the maturation of the body. We need to look at how the different systems mature at different rates, so we can get kiddies who've maybe done lots and lots of growing, but yet cognitively they're still very immature. And so what I want to try and highlight is how we can start to look at some of these young people and maybe help them get the treatment they deserve to get them better.
Definitely. And in doing so we're going to today cover your top 10 things that you feel, and I think we'd agree that physio students, new grads, physiotherapists across the experience spectrums really should know about when or before diving into treating to young people. And I think one of the things we did mention earlier is, as a new grad as well, you might find, if you've got a keen interest in sports, that you might find that actually entering into a sports team, you are working with youngsters. So I think this is going to be really important today. So if you're watching, notepad and pen, and we'll get diving straight in. So Angie, shall we start with number 1?
Yes, I think just to set the sort of scene really, is that a lot of our pathologies that we see in kids are associated with different phases of maturation. So when we're seeing that young person, one of the first things we need to establish in order to help us make a diagnosis is understanding where they're at in their growth tissue. So we have what we call peak height velocity, which is that stage where they're growing like a weed. And that invariably occurs around the age of 11 or 12 in a girl, and usually around 13 to 14 in a boy. And so there's usually this 2-year difference between the two. And what's happening then is that throughout the body, we have what we call our secondary ossification sites. And for example, where the Achilles tendon attaches to the calcaneum, you've got what we call the calcaneal apophysis. And that when that's open and the bone has that potential for growth through there, then you can get pathology at it. And that pathology won't be the same as at the adult. So one of the critical things to think about is that within our sort of top 10 is that where a tendon attaches to a bone, in an adult, what will happen is that the bone is absolutely solid, it's very strong, and the tendon is the weakest link. When we start to think about a child, if we think about these secondary ossification centers, in order to allow for growth, they've got to be fairly sort of immature, they've got to be able to change. And so consequently, when you get these constant repetition of plantarflexion, dorsiflexion going on around that, say, attachment of the Achilles tendon, what you're going to find is it's the bone that is the weakest link. So that area of the ossification site is going to be the site of some bony edema. We may well see a little bit of infiltration into the local bursa and into the local tendon. But primarily what you need to remember is that at any point where a tendon attaches to a bone, what we're going to actually find is it's the bone that's the source of the pain, not the tendon, most probably. So what we get therefore at sites like the Achilles tendon to the calcaneum is a condition called severs. If we go up to the knee and the tibial tuberosity, whereas we might start to diagnose like a fat pad irritation, or we might start to see a patellar tendinopathy, we'll see very similar symptoms, but the pathology in these instances will be either at the point where the tendon attaches onto the tibial tuberosity, and that one's got another long name called Osgood-Schlatter's, and then you've got the more the point where it attaches more proximally onto the distal patella, and that one's called Sinding-Larsen's. So what you're seeing here is that you've got really quite different pathologies. So we won't be diagnosing primarily patellar tendinopathy, Achilles tendinopathy in children up to the age of usually somewhere around 16.
Okay.
Once these secondary ossification centers have done their job and we've got all that growth and maturation of the bones, and they then close, those growth plates close, then we start looking at adult pathology.
Wonderful. And so you mentioned the difference there between female and male youngsters. So and at what stage is there a difference later on when you would start maybe expecting it to maybe be more of a tendon element? Is that different in girls and boys?
Yeah, that 2 years maintains right throughout. Okay. So in essence, your severs, if you've got a child, for example, who presents maybe a girl who we'd have expected to have fused at the calcaneal, what we call apophysis, where the growth plate is at the calcaneum. And so if a girl's presenting with heel pain at the age of around, say, 15, 16, the probability is that her growth plate will have closed. Right. So that switches that diagnosis to maybe bone stress fracture, or alternatively, an Achilles tendinopathy. Okay. Likewise, you can start to then say the boys maybe a year or two later than that. But one of the things that's always tricky is Diane Riding, who's another real ambassador for improving care in the pediatric world. And Diane, when she did some work at Manchester United and then at Aspetar, she highlighted that, say, for example, you've got some children who would have been maybe in her under 11 squad at United. Some of the children were as late in their development and they still only had the bony maturity of an 8-year-old. And yet other 11-year-olds had the bony maturity of a 14-year-old.
Right.
So what we've got there here is that we can't say by 15 all children will have had a fused growth plate at the calcaneum. They won't, because potentially some of them could even be 16, 17, 18 before they fuse. Okay. So we need to understand these secondary ossification centers, but we also need to understand exactly how mature this kiddie is, and are they late to develop or are they very early to develop, and that will change the diagnoses as well.
And so, I mean, I can tell where this is going to go today, Angie. I'm going to have lots of questions for you. But I mean, on that note, there, obviously, are there any easy ways of identifying a youngster that is early or late to develop, that might give you that idea that you still need to keep your index of suspicion for your bony injuries longer, a bit later on?
Yeah. So if you think on terms of that, what we call peak height velocity, they're growing like weeds, usually at, say, more than 0.5 centimetre a month. And that usually happens on average around, as I say, 11 to 12 in the girlies, 13 to 14 in the boys. So say, for example, you've got a boy that comes in and he's 10 or 11 and he's just done a 6-inch growth spurt that year. And maybe he's beginning to get, so kiddies start to grow from the foot first. So they'll look as though they've got wellies on, like massive long paddles. And then they've got this disproportionate size of legs. Then they look as though they've got the most enormous legs and no trunk. Yeah. And then eventually that all balances out. So where you've got a kid who is basically growing like a weed, they're growing out of their shoes, maybe their shoulders and hips are getting a little bit broader, their face is just losing some of its little podgy little cheeks and beginning to look a little bit more adult-like. Those are all signs that you've got a kid that's going through that developmental phase. Yeah. And so if a boy is hitting that at 11, he's what we'd call an early developer. If he's kind of looking like he's still pint-sized, I mean, they can still be tall, but they still look really immature, like little boys, and he's 15, we'd be going, this kid's maybe got loads of growing to do still. And if you ask the parents, were they late to develop? How tall is the mum? How tall is the dad? Where's the kid relative to that? You can use various online calculators to work out how tall they're actually going to be. And we call it predicted adult height. And then that's giving you a massive heads up that they've still got a foot to go, or they've only got an inch to go. Brilliant. So that's how in the soccer academies, they would have a traffic light system whereby you've got what we call your on-time maturation athletes. And then you'll have your ones that are early and late, and we'll be all the time tracking how far they are of developing their full adult height.
Brilliant. Okay, that's really interesting. Really interesting, and we've discussed before as well. This is so applicable to whether you're working in the NHS or private or in sports teams, because we see these active kids a lot, and this is very applicable to those, and having that awareness and of just some of those timescales and to be aware of them is really, really key. So that's really useful.
And a lot of departments that I work with across the NHS football clubs will actually just go and download things like the secondary ossification centre charts that you can get on Google. And just so that they know when those windows of diagnoses are, and they just pin them up on the wall so that you don't have to remember every bone. I just have things either on my laptop or alternatively on the wall that just tell me roughly where I'm at.
Perfect. And as we've said before, it's just having this awareness means that you'll go and look for those charts. Yeah. Whereas before you might not have looked for them, and then you'd have, some assumption there is it's a tendon, and you could have missed something quite significant in a young active kiddie. Wow. Well, okay, right. Loads of information there already. That's brilliant. I'm trying to hold myself back.
If we take that concept on, whereby we talked about that you get what we call severs at the heel, Osgood Schlatters maybe at the knee. What we need to think around as our sort of next point is the fact that up around the pelvis, so think about maybe a patient who's come with pain, maybe they're a 14-year-old and they've come in and they're a sporty little footballer, and they've had some pain on squatting, and it's over the ischial tuberosity. Now, in an adult, we'd be looking to call that a high hamstring tendinopathy. And they don't exist really in children. So if we just think for a second about the attachment of, say, the rectus fem onto the front of the pelvis, again, we may well consider that to be a tendinopathy as well if they've had pain on kicking or sprinting. Now, what happens in the adolescent patient is as those big muscles like hamstrings, adductors, the quads start to get those testosterone surges as they go through their big growth spurts, those muscles get stronger and stronger. Unfortunately, the way in which the bones are aligned and maturing around the pelvis means that until at least 17 and even as high as like 23 for the hamstring, those actual areas where the bone and the tendon join, so where the tendon attaches to the pelvis, don't fully fuse until the early 20s. So in essence, you can't diagnose a high hamstring tendinopathy until this athlete is fully skeletally mature around the pelvis, aged probably nearer around 23.
Wow. Yeah.
So these are late. So if you've got an athlete who's coming in and they've got pain at the attachment of the tendon to the bone at the pelvis, one of the bad things is that whereas with your Osgood Schlatters and your Severs, they very rarely manage to pull the tendon off that immature bone, around the pelvis, they pretty much often do. Now, if they start pulling that off at more than maybe 15 millimeters, so not very much, then that requires surgery. So as soon as we see that first sign of tenderness around the pelvis at the site of the attachment of a muscle, we've got to be starting to downgrade what these kids are doing. We need to get them onto a rest program and basically treat them as though they've either already avulsed if it's popped. So almost invariably we hear this popping sensation. Had a little boy in the other day who said, Angie, I knew I'd broken it. I could feel it just all went pop. And that's that classic presentation of the fact that they know, they feel a bit sick. They know they've done something significant. But you can actually hopefully arrest these early if at that first sign of tenderness, some of them are then reversible as long as we recognize this isn't a tendinopathy. You mustn't stretch them because they're already pulling apart from the growth plate. You don't want to start giving them hamstring stretches, even though the hamstrings will be brutally tight. You don't want to be stretching these kids. No. So that's my second one. You've got the idea that it's rarely a tendinopathy, and around the pelvis we've got this risk of avulsion.
Okay. One question I've got on that one then would be is that so you've identified this, so you've identified a potential area of tenderness you're thinking may have avulsed, but the kiddie isn't really telling you that anything, you know, that one did, said in terms of popping. What would be your workup there in terms of any imaging and any further investigations to either rule out or rule in that pathology?
So resisted isometric testing is, they usually test weak and they usually are painful on testing. So those are not only my diagnostic criteria, but also my return to play. They've got to have no pain on isometric resisted testing before they can go back to any level of running and any level of kicking. And then we also want them to, I use a handheld dynamometer, and basically I'll be testing them to make sure that we've got limb symmetry back across both sides.
Gotcha. Okay. Yeah, no, that makes a lot of sense. Wonderful. Okay.
We can't always get them MRI'd, and so therefore you're not, unless it's very rare, in fact, that you're going to get an NHS avulsion who is going to get imaged. So unless you've got some concern that this isn't settling down with appropriate activity modification, starting that isometric program to begin to get some muscle strength, and then working them through. And it takes, an avulsion probably takes 16 weeks to get them back to sport. So these are as dramatic often as your ACLs. And yet if we start looking at, do we provide that same evidence-based criterion approach for getting our little kiddies of 11 and 12 back into sport, then I don't think we do.
No,
And
no.
sadly, a lot of these Osgood-Schlatter's diagnoses are taking 3 and 4 years to outgrow their symptoms. And I think that that's just because we don't get this management right.
Yeah, and again, it's that come down to that lack of awareness
Yeah.
and knowledge in that area, and assumptions being made, I suppose.
Yeah, I would agree with that.
Mm, mm,
So the sort of, in keeping with that same idea, where
mhm,
the young child has got this immature skeleton, we need to think about our ligament sprains. So, for
mm.
example, if we took a lateral ligament sprain, which is probably one of the most common things we see as students in the adult, then we'd very much be looking at the ATFL ligament and as our probable source of pain and swelling and bruising and all those sorts of things. But in fact, what happens in the child is, in keeping with the same idea, the growth plate, particularly at that fibula, is the weakest link. So where we see that inversion injury, same mechanism of injury and same amount of swelling and bruising and all the rest of it. But as soon as you've got a kiddie who's got a difficulty weight bearing on a lateral ligament sprain, for example, you have to assume that their bone has been compromised. And what we see here is what we call Salter-Harris fractures.
Mhm.
And that's the pediatric name for an injury to the growth plate is called a Salter-Harris fracture. And you have numbers 1 to 4 of those, and the more serious they are and the more they compromise the growth plate, the more serious they are towards the 4s and 5s.
Brilliant. Yeah. Again, it just comes back to that same theme, really, doesn't it? In terms of where you're suspecting something in an adult, in terms of a soft tissue, actually, you've got to go back to the weakest link, like you looked at before and you said before, and say, well, actually, there's another area that could be is more likely to be affected, and
Yeah.
make that alternative assumption, actually. And I suppose, are you thinking in terms of making these assumptions that it's the bony element to is playing the part in these injuries? That's your safe assumption, really. Is that, am I right in thinking that? That's because that's sort of where I'm coming.
It's a much better way round to think of it.
Yeah.
You want to consider, because if you miss, say, for example, let's say you miss a fairly significant Salter-Harris fracture at the ankle, because this is a growth plate injury, and the only way that bone has got of reaching its full height potential is through the growth plate. So if we compromise the growth plate, let's say at 11 or 12 years of age, then maybe half of that growth plate can't function anymore. So one half of the bone will continue to grow, but the other half won't. And that's when you start getting angulations and
Yeah.
leg length discrepancies and all sorts of other rubbish that then really massively means big limb lengthening surgery, breaking the leg, plating it. You know, if these are missed, these are messy.
Yeah, and it can impact that person for the rest of their life in one way or another.
It really can. Yeah,
Mm, mm,
absolutely. And I don't want people to be scared of these, but as long as we have that high suspicion
yeah.
index that says, you know, I'm looking at a child, I need to understand whether their growth plate is still open. If it is probably still open, I need to consider that this will be a bony growth plate issue much, much more than it will be a soft tissue injury. It's not to say that the soft tissues might not be, involved, but it's a whole different ball game than it would be in the adult.
Yeah, you sort of play into that more serious element. So even if there is a soft tissue involved, it's the bony element that we need to be more aware
Yeah.
of and treat that. And that's always going to have the longer recovery times, the longer return to play. So if you treat that, you're going to then obviously automatically be protecting the soft tissues anyway, but that they're not so important. Wonderful. Okay, so let's move on now, Angie. I think we're going to go slightly upwards, up the body now.
Yeah, absolutely. So one of the other things that's really important not to miss, because of the long lasting effects of if we do miss it, is around how hip pain presents in adolescence. So one of the things that's really important is that hip pain often presents as knee pain, or hip pathology, should we say, often presents as knee pain.
Yep.
So for example, I had a 13-year-old quite recently. It was a boy, And he presented with like quads pain, knee pain, mostly when he was playing basketball. It had been a gradual onset, and it was just really niggly, and he'd had to stop playing sport. Now he was able to walk into the clinic, and when I examined him, he'd lost hip flexion with internal rotation. So one of the big things in the hip is that if they lose flexion internal rotation, in the younger child abduction internal rotation, then in an adult we'd be starting to think, well, maybe they've got a bit of a, maybe an impingement, or maybe alternatively that they've even got a little bit of osteoarthritis changes within the hip, and they will lose internal rotation. But obviously those aren't going to happen in these young children. And so in the very young children under the age of sort of 7 and 8, if we're losing either flexion or abduction and internal rotation, it can often be something called perthes. In the slightly older child, more around the ages of 11 to 13, then we have what you call a slipped capital femoral epiphysis. And the easiest way to think about that is if you imagine a golf ball sitting on a T-peg as the femoral head sitting on the shaft of the femur, then what happens is the actual golf ball slips off the T-peg. Now, in this little boy, it was what we called a stable able. He was able to walk into clinic, and that was still stable, but it was slipping. He'd lost his internal rotation, and the leg was sort of sitting rather externally rotated. But in some of them, they come in real acute pain, as I say, not always in the hip, but primarily they're struggling to weight bear. And these are ones you immediately put on crutches, because if it slips, say 50% at this point, then they may get away with a nail being put down through the femur and stabilize it. But if it absolutely slips, then you can end up with avascular necrosis and some fairly catastrophic surgery being required, and certainly long-term implications if those are missed. So in the hip, may not present as hip pain, it may present as knee pain. That's first red herring. And then what you're really looking for is this loss of flexion with internal rotation in that adolescent child. It is often something that you've got to get x-rayed. So really important to get these ones straight to A&E, preferably on crutches, and no weight bearing until they've been cleared, basically. Now, if there's a presence then of a temperature in a child with what looks to be some joint pathology, then again, these can go wrong quite quickly. And so we can get the osteomyelitis, and we can also get septic arthritis, both of which can destroy the joint surfaces very, very quickly. So if you've got a child who's had a recent strep throat, we're seeing lots of these sorts of things at the moment, and even associated with COVID, we're seeing a lot of viral arthritis type things. But if there's the presence of the temperature, plus or minus the history of some kind of viral overload, and they are presenting with joint symptoms, then again, they're an A&E referral straight in, at least the GP. And if you can't get the GP that day, because these guys need to make sure that the joint surfaces don't degenerate.
Yeah. So you've really got a time critical element to that one.
Yes. Yeah, absolutely. So that kind of covers us with some of the ones that tend to be a little bit more nasty if we miss them, really. And then one of the things that I thought would be good to also look at is low back pain.
Yes.
Now, the most common cause of low back pain in a younger athlete is what we call a pars fracture. So it's a bone stress injury. And the posh name for a lumbar stress fracture is either a pars, because that's where most of them occur, and the pars interarticularis part of the vertebrae, or to give it its real name, a spondylolysis. So I usually just refer to them as lumbar stress fractures or pars fractures, because it's a whole lot easier to spell. But these are going to present with invariably in something like, because I do a lot of cricketers, so we may well be looking at, say, a right arm tennis player or a right arm bowler at cricket, and they will present with left-sided low back pain. So single-sided low back pain, on the opposite side to the dominant arm. Now, what I'm doing at the moment is some research in football to try and establish, is it more on the stance leg or is it more on the kicking leg in soccer players? And we're doing some research on that at the moment because the jury's out. But in rugby players, most commonly, I suppose, because of scrums and things like that, it's most commonly bilateral. So the only real group that it seems to occur bilaterally in is the gymnasts and the rugby players, which you can imagine because they do a lot of stuff fairly symmetrically, as opposed to the overhead athlete is much more likely to get one of these stress fractures on the opposite side. It can then spread and end up on bilateral. And in fact, I had a boy today who had a bone stress injury at L4 on the left and right and L5 on the left and right. He's taken the prize at the moment for having 4 simultaneous stress fractures.
Gosh.
So, but these present as usually pain on extension or pain on side flexion, not always. Sometimes have a restriction of things like straight leg raise, but it's the history. I've been doing lots of extension based kicking or throwing. I've always had a spike in activity. So we see these the 3rd week of the footy season, the 3rd week of the cricket season. They've always had like a big spike in activity. And then they've developed this pain. And initially it's like intermittent, and then it settles down with rest, and then it comes back, and then it starts to get more frequent. And by then they've fractured.
Right. Okay. And so management, obviously, so we know sort of from an adult management point of view, what sort of management overview have you got in terms of those? If you identify one of those and they get identified.
So the most important thing is we can reverse most of these if we pick them up at that intermittent low back pain. So a lot of it is about doing what I'm doing now, raising awareness, so that if we see this kiddie with intermittent low back pain that's extension related, then we pull them out of sport for at least 2 to 6 weeks. So I power them down completely for 2 weeks, and they can cycle during that phase because it's in flexion. But no running, no jumping, no kicking. And then we basically start to do lots of like looking at their breathing, looking at their core stability, glute activation, lots of teaching them to move again. A lot of these kiddies just literally lose the ability to sort of hip hinge, to squat, to lunge, going through the growth spurt. So it's about kind of maybe doing a bit of movement re-education as well. And then gradually over a 12-week period, building them up to make them more robust, gradually adding in more and more activities.
And then would you also then, I'm thinking in terms of from an adult point of view, obviously, would it be the same in terms of gradual exposure to those mechanisms of injury back to back?
Definitely, yeah. So you'd start them off, maybe they're only doing cycling, and then they can perhaps bring in some aqua jogging. They can maybe run in water, and then eventually they can start to swim front crawl, because that takes them into some extension, and then we may let them do some running, and then they can start to bring in the sprinting, the kicking, and the throwing. And initially we'd be like, you can only kick a ball a short distance, or you can only throw a ball a short distance, and then gradually increase those margins.
Brilliant. Okay, fantastic. So yeah, okay. Right, where are we going next?
So quick look at the knee. So in the knee, if we saw a adult that had locking, maybe giving way, very mechanical symptoms, what would your kind of go-to diagnosis be?
So you're going to start thinking of sort of meniscal tears and
now you can get lateral meniscal injuries in young children, usually under the age of 10, but they're rare. So if you get locking and giving way and an effusion in the adolescent knee, it will be a osteochondral lesion or even a stress fracture. And so what happens is, if you imagine this joint surface is still very immature, it's quite fragile, then what we actually get is almost like a little flaking of the joint surface. And these are called osteochondral defects. Right. So osteochondritis dissecans that you can get in the elbow, but we also see them a lot in the knee. And again, these need looking at because they're like a little 5 pence, 10 pence piece of damaged cartilage that if it's not given that time to heal at this point, and even sometimes they have to be surgically pinned back down again because they've fully come loose.
Right.
So these are another one that do need an MRI scan, and they need to be really well managed, and they'll be off sport again another 4 or 5 months just to make sure that these have settled. So locking, giving way in, and swelling, you can get an ACL, but they're most likely to have avulsed the ACL from the tibial component, not through, there's not usually a ligament damage. It's usually that they've actually managed to pull the ligament off the bone. Again, going back to that same analogy of the growth plate is the weakest link.
Yeah.
So it's just that, I just thought that was worth bringing in the knee.
Definitely.
And then the two things that are associated, or one of the big things associated with osteochondral defects, but in my belief, almost all of these childhood pathologies, is low levels of vitamin D. So at the moment, if you think about a young child, their mother would be irresponsible if she didn't slap them in factor 50 all summer long. As a result of which, they're either in long sleeve tops, and certainly in the UK, they're covered in zillion layers to keep warm. Or alternatively, maybe they play an indoor sport all year round, like swimming, gymnastics, and those sorts of sports. Or they're covered in factor 50. All of which means their ability to absorb vitamin D is exceptionally limited. And so we often think that there's a big association, certainly obviously with our lumbar stress fractures, but we're seeing a pandemic at the moment of tibial stress fractures, calcaneal stress fractures, femoral stress fractures in that adolescent population and in those early 20s. So really, really important to make sure that these guys end up on some vitamin D, and even as much as 2,000 and 4,000 IU a day is what's needed in order to get on top of this. So that's one of the things that we think sits behind a lot of these growth plate disorders.
Yeah, absolutely. I would use, is that an all year round thing? Because I know from an adult perspective, it's recommended from, I think it's from October through to March, when in this hemisphere we're not able to, the wavelengths aren't the right length for us body to then convert to vitamin D. Is that the same in children, or would be a recommendation actually it should be an all year round thing based on some of the things you've just said?
Yeah, I mean, I think it would be really hard to tell a parent to give their child 20 minutes of high intensity sunshine without sunscreen on. So I think that we'll probably get to a point where kids are on it. These, as we say, the sort of the growth plates finish maturing, lumbar spine 23 to 25, most of the stuff around the clavicle late 20s, pelvis early 20s. So you're basically talking that up really well into the 20s, we probably ought to be advocating that youngsters ought to be taking vitamin D just routinely, all year round.
Yeah. And again, that's a real awareness thing, isn't it? And it's likely to hopefully become more prevalent, or more more talked about, I suppose, is the
So we've hit number 10, James.
Fantastic.
Children still get nasties. So we just need to be aware that growth tissue is very, very obviously fast to replicate itself. Therefore, it's highly metabolic. And when something nasty comes along, it goes nasty very, very quickly. So in just the same way as we would ask an adult the red flag questions, do they get night pain, weight loss, all of those things, and particularly in kids, do the features fit? Can you make sense of the symptoms? Something that's predominantly these tumors occur at the end of long bones. That's where they're massively metabolic. It's where the growth plate is. So if you've got any form of swelling over a growth plate, these guys need imaging anyway, because you've either got maybe a Salter-Harris fracture or you've got something nasty. So if it doesn't make sense, you've got pain towards the end of a long bone, or you've got deep bone pain, because growing pains do occur in children in the bone when they're growing, but primarily growing pains are bilateral, malignant pains never are.
Right. Okay. Yeah.
So that's the easy one. If you've got a kiddie with like they're just saying that they've got night pain and it's both shins that are hurting, which is most commonly where what we'd call growing pains occur. Check the slump, because it's often neural. If it's bilateral, the probability is it is growing pains. If it's not bilateral and it's in the bone, get them seen. Okay.
Yeah, that's two really important things there is, children still get the same. So we've talked very much about how they differ, but actually there's, some things there that you still don't go off piste. Your red flags are
red flags are red flags.
Yeah, absolutely. And your index of suspicion, you never clear red flags as well. So you are aware of them all the time and you check them and if things change. So that's really, really key. Wonderful. So we've done 10.
We have.
They're so smooth as well. We went through them so well, very brilliantly.
Do you think I talk about these 10 things quite often?
Well, it's been really useful, and I think I know I wish I'd seen this when I was a student and just graduating. I think it's covered so simply but really effectively, brought to light some really what are actually really important things, and I think it's going to be very, very useful. Question that I've got, just a theme that's kind of come through this and that I've heard a few times on a lot of these pathologies is you've got the potential to sit there and ask a young athlete and parents for them to sit out a sport for quite some time. And that's going to be, I can imagine, a very, very difficult conversation. And I know I've had conversations like that in the past, and they can be really tricky with youngsters who are, I found it particularly around some sports, that gymnastics, swimming, where it's very obsessive, it's very intense, and there's an awful lot of pressure. Have you got any tips on how to have that conversation? I know this is probably a day-long course in itself, to be quite honest, but any tips around that?
Yeah. So first things first, when you're diagnosing a child, you've got to be honest. So one of the massive things that's come out of Ben Smith's work at Nottingham and Mikhail Rathleff at Aalborg University is that children want honesty. They want you to be giving them practical advice about what's involved, how long they're going to be out, what they can do to help themselves. So that's the first thing, is don't try and dress this up as something that it's not. Because if you've got a kid who's going to be growing for 3 and 4 years, and potentially something like Osgood Schlatters may rear its ugly head every time they have a spike in activity and a growth spurt, then we want to be really honest with these kids. And so when you've got things like your Osgood Schlatters and your Severs, what we'd call the non-risky avulsions, they're not going to do anything. You can allow them to play with pain. So you can teach them that it's okay to have a 2 or a 3 out of 10 pain. And on the days where they're not too bad, they can play. But on the days where maybe it's flared up because they've done too much the previous day, they're going to have a really quiet day. And so one of the things that's really important is to give them some dialogue. Exactly what is this condition? How do I describe it to my PE teacher and my mates that one day I can play and one day I can't? So actually pre-preparing some good descriptions as a young therapist to say, this is what Severs is. I've got a little handbook on Osgood Schlatters. I'm just about to do one on Severs. I've got one on pars fractures. So the viewers can all get those downloaded, but start preparing some of their own dialogues so that they've got something that's just going to roll off the tongue. This is how you can use it in a language that's going to be understandable to the child. So it's the right sort of maturation stage, and that they can use to describe to their mates. And that helps enormously. And then you've got that buy-in. But if you've got something more like the avulsions, the pars fractures, the osteochondral defects, that they are going to be out for months, what I'll do is often say to them, look, this is going to be a long slog, but what defines you as an athlete is how you respond to that. And the more you stick to my program, the more that you're going to benefit from this. And I'll pretty much guarantee you that if you do all the advice I give you and you do the exercises, number one is you'll probably get better quicker. And number two is you'll probably come out of this finding that this has been an opportunity to develop lots of the sports skills you don't normally have time to work on.
Yeah.
So I'll always give them a challenge by saying, look, what is it that you want to be better at skill wise? What is it that if I asked your coach, they would tell me you're not that good at, you need to work on? And then let's work on that. Let's find some videos, let's break them down, chunk them, start to look at what physical skills you need in order to be able to do that. And let's incorporate that into your rehab. So when you come out of this, you're actually going to be better than when you went into it. And we talk about mirror neurons and how if they're watching videos of themselves or other people doing the techniques, it helps the body to learn things quicker. So always giving them projects, engaging them in their learning.
Yeah, I suppose that fits really similarly in terms of what certainly my ethos is with treating adults is you look at what they can do, not just what they can't do.
Yep.
And then you find opportunities for them to develop. So when they do go back to their sport, they actually are possibly better than they were before they left, other than just basic fitness and sort of match experience. So, or team experience. So yeah, I think that fits quite both. It's probably a skill that could transfer between the two. But as you say, it's really key is that giving the kiddie the information and not holding back. Obviously hit it and give it at the right maturation stage and in a way that they'll understand, but not being afraid to actually really give some information and make sure they're aware of exactly what's going on rightly, so they can then explain it to their friends and their PE teachers in a way that actually is understandable as well. So I think that's really important. Wonderful. So Angie, that has been, I can't honestly, it's been absolutely fascinating just for me to listen to. And I know as a student and as a new grad, this is going to be so useful. And just that awareness, as you said before, you're not expecting people to now all of a sudden to go away and be experts in this, but it's about just having some of those conscious awareness now, things that you now, hopefully, if you're watching this, want to go away and look into more. And also if you do see youngsters, you'll just be aware of those things that you need to be aware of and that you need to pick up on. And it will be, as I often say, in your early stages of your career, these are things that you're going to pick up on and go straight to your senior with. You're not going to sit on yourself.
You don't need to know everything yourself. No. So that's going to be really useful. Now, for those, I'm sure everyone watching this who does want to know a little bit more, you do run some fantastic courses. Angie, do you want to just give us a bit of an overview of what courses you do and how people can access them? Yes, of course. So you can either learn with me online. I have a course called Active Kids Are Not Mini Adults. And then that's grouped together with some masterclasses that I've done on the knee and the lumbar spine. And then we're just releasing at the moment the upper limb one as well. So lots of ways to do like online pathology courses. And then in addition to that, I also run face-to-face courses as well. So I'm all over the place this year, from Newcastle to Exeter to Northern Ireland, and a little bit further afield as well. So there's opportunities to do 1 day, 2 day courses with me in person, which I think are great fun. We do lots of me being a big kid and doing return to play type protocols. And then, as I say, lots of different online short modules or the full, like everything you need to know, the whole youth athlete toolkit that enables you to basically get that job in sport if that's your chosen field.
Brilliant.
So but let them reach out to me. I do a free monthly newsletter, and they can sign up for that. Lots of different freebies that are always on my social media, which is at Angie J Physio.
Wonderful. That's great. And I would recommend for sort of following some of the stuff on social media, because you don't bombard social media, but everything you put up is actually really useful, which is always really nice to have, because we do, and I know students out there will agree with this, we get bombarded with so much stuff on social media. So I think having yourself it's like those people who don't talk too much, but when they do talk, it's really worth listening to. So that's how I would describe it.
That's really nice. Thanks.
So Angie, thank you so much for your time. We really do appreciate it, because I think it's really an area that is well needed in terms of things that the undergraduate degree cannot cover because they just haven't got time, you know. So and I've always say it gets a bit too much bashing sometimes, the undergraduate degree. I think there's no way it can cover some of the things that people expect it to. So that's why, you know, people like yourself running great courses, hopefully some of the videos that I put out just give that little bit more meat on the bones and give people a skeleton framework to carry on their CPD and their experience and knowledge. So hopefully this has been really helpful. I know it will be. We're definitely, I think, going to have to organise another session on covering some other things. So if you're watching this, yeah, and if you're watching this and you think, actually, I'd like to know more about something, do let us know either to myself or Angie or in the comments below, and we'll see if we can sort that one out. So Angie, thank you so much. I'm going to let you go. For everyone out there, do remember to share this far and wide. We want to try and get this out to as many physio students and new grads out there. And have a lovely rest of your day, your evening, your weekend, or your week. And I shall see you in the next video. Thanks, Angie. We'll see you soon.
Thank you.